Pleasure to see everyone, and welcome to Coffee Buddies, which is well, it's how many have we done so far? We've already done 3, I think, Graham, or is it 4?
This week, yeah, absolutely.
Yeah. So the week has been going on, and we're part of the Biotech Gate Festival, which, as you all know, is our lovely friend Patrick's gig. And it's welcome to everyone. And remember, our mantra is inform, engage, and entertain. And today we're lucky enough to have Mike coming along to tell us about his journey and his adventures, really. So Mike, maybe you could tell us who you are, what you are, and what you do.
Sure. Well, hi everyone. I think I know most of you anyway, but if you don't know me, I'm Mike Davies. I'm the CEO and founder of a company called Carocell Bio, and we're developing novel peptides, small proteins, and using a nanoparticle delivery technology, nanoparticle transfection, to more safely treat inflammatory diseases. And I'm here today to tell you about how we've progressed a bit with a bit of investment we got and where we got that from and all that sort of thing. So that's basically what we are.
Fantastic. And you've got a few slides that you're going to show us, Mike, just to help us with your telling us what you do and how it's going.
There we are. So yes, so basically we're trying to generate healthier skin, obviously, for a better life, and that's the sort of plan. It all started out. I started life as a pediatric cardiac surgeon at Great Ormond Street, medical training and all that sort of thing. And I've created so many scars in my life and not really batted an eyelid, because that's what you do as a surgeon. You create scars, you save people's lives, you do things, you get all sorts of things, but basically that's what you do. Whereas from the other side, from the patient side, and I got more and more into this, the scar becomes a major part of their life afterwards, because they're better on the inside, we've cured their heart disease is what we were doing, but you leave them with a great big scar. And that does cause problems, certainly more so in girls than in boys, ladies than in men. Do we call them all they this year? Now I don't know, but it causes a big problem. And so this is where we got how we got. Now, from my background, I know that scarring is driven by the inflammatory process you see. So when you make an incision, dive in, do your operation, come back out, suture, stitch up the skin on the outside. Over the next few hours and up to the next week, you see a redness around the scar. That redness is inflammation. It's not, in most cases, it's not infection. And you know when it's infection. Generally, most cases, it's just inflammation. That inflammation drives the collagen, which forms the scar, and we just assume so. We generate scars because, back in the day when we were out, the males, I can differentiate in this bit, when the males were out hunting and the girls were at home preparing the dinner and looking after the offspring. If we got injured, the first thing you needed to do was stop bleeding. That's why we developed platelets and the clotting system. Very good. The next thing you need to do, of course, is fill the hole to stop other things falling in. So that's why you fill it full of collagen, and that therefore you can survive and get back, type thing, to your your lovely dinner that you've caught and all that sort of thing. With that formation of the scar, the collagen is just thrown in the wound to seal it as fast as possible, stop things falling in, and you get a bird's nest of collagen. We all know that bird's nest is not as strong as your normal skin, and it's what happens. But the science says if you can modify the inflammation and reduce the collagen deposition, you will reduce the scar and probably make the skin stronger, because instead of this bird's nest of collagen, you'll get it laid down in sheets, which is how our normal skin is. So blah blah blah, we started Carocell Bio. We got friends and family, fantastic couldn't do it without them. Then we got Innovate UK grant. Innovate UK grant was to look at burns. Now we know with burns you get a massive inflammatory response. It's enormous. That inflammation, you can see in these pictures, the redness that you see, that is inflammation. And that inflammation leads to collagen, leads to the scarring you see after a significant burn. We know that if you reduce the inflammation, you reduce the scarring. That's why we use cold water, because it's the only thing that's available. In this is a Netflix, documentary. If you've not seen it, I recommend you see it. Called The Volcano, White Island. In December 2019, there were 47 people just going on the island having a look. Looks beautiful, blue skies. An erupting volcano. Well, it erupted while they were on the island. 47 people, 22 people survived, the rest died. And of those 22, they all had over 50% body surface burns. It was a particular type of volcano that was basically ultra hot water and ultra hot volcanic gases, over 200 degrees C. They went through your clothes, and this guy you see at the bottom here, who turned into this guy here who survived, this is him, this is a few weeks after, and see the mess he's in. He has massive burns, and you see his face here. The rest of his body is scarred. That scarring is because of the inflammation that leads to the collagen deposition. So this is the recent data. This is some of the recent data that we've got. So we know with our peptide with nanoparticle delivery from the cell data, we switch off inflammation, but we also prevent the activation of inflammation, which will be very important in other things that we've looked at. But from the burns, we've got some really, I find it really interesting data. Okay, I find it really interesting data. When you look at it, you kind of think, yes, you don't really need to do that. But anyway, what we showed that we took biopsies from people who've been burned. We took biopsies from the center of the burn. We took biopsies from the very periphery of the burn, the peripheral burn, and we took biopsies from a bit further distant, which we classed as unburned. Interestingly, the unburnt skin has really high levels of inflammation markers. The burnt skin from the center in the middle has relatively very low levels of inflammation markers, which, if you think about it, well, of course it does, because the skin's been burnt away. There's no inflammation there. And then on the periphery is a bit like the further around. So to me, this says, when you treat a burn, yes, you treat the burn, of course you do, but you have to treat the surrounding skin as well, because that's where all the inflammation happens to drive in the things to stop you dying from your burn. What we showed here, as you can see on this one here and this one here, this is 24 hours and 48 hours, we significantly reduced those inflammation markers with our peptide. This is in people who've been burnt. This to me is amazing because we are a peptide, this is a burn, and you can see the inflammation, the intense redness of the inflammation in this young person that has been burnt. We've also got data in people who have atopic dermatitis, and in that study we actually compared to a steroid, clobetasol or close something or other. I can't remember the name off the top of my head. It was a question. Yeah. Do ask questions, please.
Well, I'm just one curiosity. Would you describe the cells in the center as necrotic?
Well, yes, they are. they are in this picture, which is when we get to taking the biopsies. They've actually removed the necrotic skin, but in a third-degree burn, which this one is a third-degree burn. Yes, you've got necrotic cells initially, and then surgically, what we do is remove the dead tissue, the necrotic tissue, so you get to this top picture up here, and then you graft it, because that's all we can do. Yes, it's necrotic. And these data strongly suggest that.
Brilliant,
but
interesting.
And it's interesting to me. I was actually expecting the actual burn itself, the area of the burn, to have the highest levels, which, of course, when it's been burnt away, then no, it's
necrotic. It's not going to be. It's just not going to be.
Yes, exactly.
Generating, is it?
You're exactly right. That is the case. And so with our peptide, we've shown we can bring it back down to, necrotic levels, low levels, not low levels, not necrotic levels, low levels.
Is there something about the unburned on the periphery? Is there something about the 3-dimension where you've got underneath the burn, you've got a vascular bed. So is there a 3-dimensional thing going on as well, Mike?
Absolutely. In the inverted commas normal skin, the skin that doesn't look burnt in this picture, in that normal skin, there is the full skin architecture. It is that area, the surroundings of the burn are very much stimulated, as we can see here. It's very much stimulated by the burn, and it needs that stimulation to drive the blood vessel growth and the influx of cells to try and preserve the area that's been burned. So yes,
very interesting.
Well, there we are. So we've got data that now shows it works in human tissue. Now that works in the burns tissue. Burns will, in terms of burns, there is a market for burns. It's described as a $2.3 billion market. But more interestingly to me, I've spoken with, and we're in continued conversations with the US military, and they are very keen on taking on the burns project, because they want to look, yes, at thermal burns, of course, but they also want to look at radiation burns and chemical burns, which will be very interesting. However, if whatever that doesn't come through, it's still in discussion. We are wanting to drive this program forward, and we're a bit of a quandary, because big pharma doesn't like burns because they've got no method of selling in burns, because they don't have anything in burns, because water is all that's available. But scar reduction, prevention of a scar after an operation, which is the same mechanism, is a much bigger market. So this is for the development of something to prevent the formation of a scar after an operation. We're looking for a total of $3 million over this next year, 10 over the next 2 years to get us through to IND, and 20 to 30 to do the clinical proof of concept. So, 30 to 40 million to get us through to clinical proof of concept in 4 years. We've got 2 investors who are very interested. I'm meeting them again on Friday of this week to talk about strategy and all that sort of thing. We're seeking another or more to help fill the round, but things are definitively progressing. And now that we've got data that says it works in human tissue, just as we will give it in the clinic, literally we took the biopsy, put our formulation on, and measured the markers underneath. Well, that's just what we're going to do in the clinic. We're going to treat it topically. I see it as a spray, and for preventing the formation of a scar after an operation, the spray will be applied to the incision line and the surrounding skin, which is what the data suggests, not just the incision line, the surrounding area, at the time of closure, and then every day for 7 to 10 days is what the science says, the inflammation. So that would be the plan when we get to the clinic. And that's about it, really.
Great.
We've got a great team. We've got a fantastic team, and with investment we'll grow the team, of course, but we've got a great team as we are. Thank you.
Very good, very good. If you take off the presentation, Mike,
Yep.
and then we'll ask if there's any questions.
I think we'll have 1 or 2 questions, and then we'll go into the groups and people can ask you. But I think, firstly, well done, Mike. It's going brilliant, and we should thank Mike for a very interesting presentation.
Thank you very much.
Any